Good afternoon, everybody, and welcome to our Baltimore City Health Department Town Hall. I am very excited today because we are talking about long COVID. We've gotten a lot of questions on long COVID, so very, very excited to have Dr. G here to talk about that, as well as pediatric COVID and our vaccination planning. We'll maybe give it about 30 to 60 more seconds and let folks hop on, and then we'll dive right into it. We do want to leave plenty of time at the end for questions. So please, if you think of questions, type them into the comments and we'll try to get to what we can. Again, thank you all so much for joining the Baltimore City Health Department Town Hall today, April 29th. Again, if you're just hopping in, thank you so much for joining the Baltimore City Health Department Town Hall today. Today, our topics are long COVID, pediatric COVID, and pediatric vaccinations for COVID. For the sake of time, we will go ahead and get started. So we're going to start talking about long COVID. So I have the distinct pleasure of introducing our first panelist, Dr. Panagis Galiasetos, who is an assistant professor at the Johns Hopkins School of Medicine and a physician in the Division of Pulmonary and Critical Care Medicine. He is also the co-chair of the Johns Hopkins and is the co-director and co-founder of Medicine for the Greater Good. During the pandemic, he assisted in vaccine equity throughout the city of Baltimore. He cared for patients in COVID-19 intensive care units and assisted in establishing post-COVID-19 care. Further, his community outreach resulted in an international curriculum for young people on COVID-19. He has been to and held hundreds of town halls to assist the greater global community in understanding the pandemic and how we all play a role in ending this general crisis. His additional clinical responsibilities center on critical care services in adult populations. He's the director of the Tobacco Treatment Clinic at Johns Hopkins Medicine. He's the associate director of the Hereditary Hemorrhagic Telangiectasia Center at Clinical Excellence and physician in the Obstructive Lung Disease Group at Johns Hopkins Medicine and in the post-COVID-19 acute clinic. He has authored books and over 80 research articles on community engagement and its impact on health and health equity. Again, it is my honor, my pleasure to have Dr. G as our first guest today talking about long COVID. So welcome back, Dr. G, because you've been with us before, and we're really excited to have you again. I know the last time you were on, we had so many questions and so many things that we didn't get to cover. So I'm excited that we're going to spend much more time focused on long COVID today, because this is a topic that comes up all the time. So maybe we'll start with just a really general question, right? Because you read so much. So, what is long COVID?
Right. So general question, complicated answer, and I'll dive into that. But good to be back. I really love being here. And today I'm taking pride showing off my Oriole gear.
I see.
It's baseball season. So long COVID, right? So I'm going to dive into, there's literature out there, et cetera. We're all in real time, really here as well, trying to build a plane and fly it to try to best characterize it. And the reason why the naming is so important is because with the appropriate name for the appropriate symptoms, we can hopefully get the appropriate targeted therapies.
Yeah.
So a few things that I want to lay out. We have known for 100 years at least that after a bad infection, viruses especially, you will get some post complications. And that's key to recognize, because in our clinic, for instance, we try to understand if your symptoms are part of healing. Right after, it's like breaking a bone. I can fix the bone, but you're going to be in some aches and pains until you're back to running again. Did it potentially unearth another disease? Like a lot of my patients with asthma, guess what? COVID is a good asthmatic trigger. And so their post-COVID complications are really centered around a disease that we know of. So we try to tease those two out immediately. Is this healing? Because we don't want to deviate from that. And usually we'll tell patients, we'll manage symptoms here and there, but we're not going to do any disease-targeted therapies so we can let you heal appropriately. Is this part of kind of another disease process that's come on, and we'll target that appropriately. After about 4 to 8 weeks, maybe even 12 weeks, if your symptoms continue, and now these are symptoms that don't fit into a box that we know of. Fatigue, I mean massive fatigue, chronic fatigue that's been lingering. Chest discomfort without any obvious imaging or lung function test abnormalities. headaches that can't be explained. Like if these symptoms persist beyond 8 to 12 weeks, that's when we start calling it long COVID. That's what gets our attention, and we begin to look to see how we can help our patients at least manage the symptoms, ultimately for disease treatments in the future. But that's, we try to put it in one of three categories after the viral infection: healing symptoms, a disease we know of symptoms, or is this, in my opinion, that's what I call long COVID, symptoms that we can't explain by a known disease entity at this moment.
Great. Now, when you went through that explanation, which I think was very helpful, you identified three potential symptoms of long COVID: the chronic fatigue, the extreme headaches that aren't explained by something else, or even, chest or lung discomfort. Are those the most common symptoms of long COVID, or are there other things that you
There are others, and again, you can hit it from head to toe. The brain fog that is there is actually, to me, of all the symptoms I've seen, this one is the most heartbreaking. I'm a physician for adults, right? Did my training in internal medicine, and that means I've dabbled a little bit in geriatric, and seeing patients, especially with early onset dementia, breaks your heart. But I'm seeing that same level of symptoms in like a 30-year-old who's sitting there having a conversation with me, and you can tell they're trying to find the right words. And I look, in my chart, I'm like, this is a 30-year-old, high function adult, right? Some of them have been CFOs, some of them, have been other physicians. Like, these are high functioning people who are having such brain delays in getting words out. So that, to me, is my most concerning symptom, and we definitely see it. So from head to toe, we can see cognitive issues. We can see mental health issues with anxiety, depression as well kick in. From a cardiopulmonary, the shortness of breath that we really can't, or chest discomfort that we can't explain by a disease process. And it tends to come on at moments that shouldn't, right? If someone's like, oh, I get chest discomfort if I run a lot, great. Maybe it's deconditioning. But if you get chest discomfort just from sitting down, right, then that's to me more of synonymous with long COVID. Also, inappropriate heart rate rises, the kind of a dysynchrony between what the heart should be doing and what you're doing. We see that from a cardiopulmonary standpoint. And a lot of muscle aches and pains as well are the other symptoms. So there's a lot. The one that I see almost universally throughout everyone, though, is that fatigue. And one of my patients, I really don't want to dismiss that because I don't think the word alone captures it. One patient described it. It's like anchors constantly pulling you down, unable to do your everyday work. So those are, yes, so it can strike from head to toe. And the key part here is there's symptoms that you really can't place with another disease, right? They are very separate.
So I think you touched on this, but just to make sure that we're clear, if someone is sitting at home and they're wondering, how do I know if I have long COVID? So you touched on these symptoms, what's most common, what's potentially not related to another disease state, but maybe you could also speak to the time frame or like recognition of a previous COVID infection, and how does that play in with someone now wondering, do I have long COVID?
Right. So, and again, this is key because these symptoms that we discuss for long COVID really are subjective, right? They're the patient's own understanding what's going on and so forth. There's some level of objective tests that we can do, like for cognitive delays and so forth, or cognitive issues, or for your mental health. We have some objective tests that we can do, but really it's subjective. And this is where we really rely on patients to kind of be in touch with who they are. Like, yeah, I've noticed myself being different post this. And I see this because this is the tough part. When we get patients showing up into our clinics, and a little bit of a gender difference, we'll see our female patients showing up around that 8 to 12 week mark. My symptoms haven't gone away. I want to know what's going on, right? And then we start tackling them. So, for the listeners out there, around the 8 to 12 week mark is when we start thinking about long COVID. Prior to that, by the way, if you're having symptoms, you don't have to wait till the 8 to 12 week mark. Start talking to your primary care physician, because at least they can also tease out the other stuff and help you with some symptom management to make your life a little bit more comfortable for the time being. Like, it's like if you broke your bone, you're going to get some pain medications as you heal, right? You want to be able to do some symptom management for healing. Now, the male genders, we tend to see them coming in a year later, dragged by their partners, and say he hasn't been himself in a year.
Sure.
That's key. Like you don't want to dismiss these symptoms. So I would say if you're out there listening, if you feel like you haven't been yourself again, start talking to your doctor. If you are a loved one and you see that in another loved one, grab them to go into a doctor so they can start having these conversations. Like we got to advocate for these patients because their quality of life has been robbed.
Yeah. Great. No, I think that's helpful to know. So, along that same line in seeking help, do you advise that someone start with their primary care clinician first, and then that person could refer as needed, or how would someone go about doing that?
Yeah, so and I'm going to tackle this in a way that I've kind of evolved of my own recommendations with this. So I would start off with your primary care physician because well, the primary care physicians will do well, right? Your initial touch point is, and many when I've gone out and give lectures, I was like, know what you guys are good at, right? You're good at picking up things that are associated with these symptoms. So have your primary care physician tease out the common things, right? Because not everyone with these symptoms post-COVID will develop post-COVID complications, right? If some of them are diseases that your primary care physician knows, he or she will tackle it. Like one of my favorite patients came to me having these symptoms. We realized her iron level was low. The primary care got some iron infusions. The patient's like, I don't know if I need to see you anymore. Like everything's been resolved. So work with your primary care physician first. He or she will sleuth through, trying to tease out if this is healing and trying to tease out if it's a disease that we know. When to start tapping into kind of a more specialized clinic like we've developed here in Baltimore at Maryland and at Hopkins is if these symptoms have lingered beyond the 8 to 12 week mark, and your primary care physician is like, we've tested everything, we can't figure it out. Let's send you to the groups who are actively pursuing this. And keep in mind, the one thing I want to prepare all the listeners if they're coming to us, this is not something we've learned in medical school, right? So while you'll become our patients, you have to understand you're going to also become our teachers at the same time, because we're going to work together trying out a variety of hypotheses to help you.
Yeah. And so I think that, just to touch on one of the questions that we have from someone who's watching, because I think that this aligns well with what you were just talking about. This person notes, Melinda, infectious triggered complex chronic illnesses have been malaligned and stigmatized for decades. So chronic fatigue syndrome, POTS, dysautonomia, for example, aren't new. They just haven't been taught to clinicians, and patients have not been believed. And I think, probably both you and I know that tends to be, those tend to be diagnoses of exclusion, right? And so oftentimes we're looking for other things first. So certainly understand that's been this individual's experience. So the question is, what is the health department and/or Hopkins doing to get clinicians, especially primary providers, trained to not only recognize but to begin to treat? And you begun talking about how you're working with physicians. Can you tell us more about that?
No, again, my heart goes out to patients like that, and I say this because what patients do carry into our clinic as well is a feeling of stigmatized and judged, because they went through, some patients have gone through 12 doctors before they get to us, and everyone keeps telling me I'm normal, and I'm like, that's not what the tests really are implying. You just remember, I try to tell patients, you got to think of school, right? No one gives you pop tests, you give you tests. They give you for tests that they hope of information that you know of, right? That's what we do in medicine. We test for diseases we know of. So if we tested you and it came back unremarkable, we just didn't find a pathology that we're aware of. Long COVID is very new. And so from our standpoint, one way we are trying to make sure patients feel heard without any stigma, without any judgment, is we go around talking to as many primary care physicians as possible, right? Post-COVID consequences, post-viral consequences, as our viewer said, these aren't new. These are well established for decades. And yes, some of them are diseases of exclusion, but we got to make sure we remove stigma and judgment because they are not necessary. Those will create frictions in the patient-doctor relationship, which in my opinion, especially in post-COVID clinic, it's the most valuable thing. I mean, we've had patients who would just say, just being heard and listened to and being believed has done more for my mental health than anything else. And if we start there, great, until we figure out what's going on. But one of the things that I promise the viewers and listeners, we are doing as much educational conversations to make sure physicians understand the gravity of this. And it's tough for doctors to have a disease that we can't test for. It is frustrating, but it doesn't mean we need to project that frustration onto patients. Always believe them. And if you're with any provider where you feel like you're not being listened to, go to the next one. Come to us. We'll always advocate, but that's what we promise. We are out there advocating as much as we can.
And maybe when Dr. G refers to us, we can drop across the banner, what the information and what clinic he's referring to, so that our viewers have that information. I might ask you one more question, and then we'll try to, if you can stay on till the end, we'll get to a few more. But when we think about educating, providers, that's critical. But we also know that now, there are employers, right? And we have, employees that are experiencing long COVID. And, do you know of any work being done to educate employers on the implications of long COVID and in terms of disabilities and the support that employees need?
So actually, and I love this question because I'm doing my first talk to a big employer group in DC in mid-May, where I'm going to go down and have these conversations. Because I see this because, look, where we're at now in April 29th, 2022, we have the weapons to make COVID non-life-threatening. That's great, right? I'm about to be in the ICU this weekend. No COVID cases in my intensive care units as of right now. I love that. That's fantastic.
That's amazing. Yeah.
But we've got to be mindful that COVID is still life impacting, right? Long COVID is one of them. And every employer needs to be cognizant of that, because if your policies, for instance, aren't geared to not catching COVID, your staff may catch it and really need to take quite a bit of time off as they recover. And goodness forbid if they do get and develop long COVID. That is life-changing for many people. So from my standpoint, that education, you're spot on, from Dr. G to Dr. D. It's got to be conversations that every employer's got to be aware of, because it's not about just missing work for a bad cold. Long COVID may cause patients that drastically change their lifestyles, and we've seen that happen to date.
Yeah, so maybe one more, because I think this is also a good one, from a listener or viewer. My parents just caught COVID for the first time. I hear you saying that most people start coming in around the 12-week mark, but I'd like them to be more proactive. When should I tell them to go in? And I presume, it's related to when should you tell them to go in as it relates to long COVID?
Yes. So the long COVID to me starts surfacing as a differential, key around that 8 to 12-week mark. So it doesn't, and you're right to the listener, you don't have to wait to the 8 to 12-week mark. It's just usually with that time we can start differentiating, is it long COVID versus something else? For anyone who got COVID, I would start immediately talking to your primary care physician so they can help you with the recovery. Like that can happen the next day, the next week, right? Because sometimes there are things you can do to make sure the healing stays appropriate. Sometimes to manage potentially a disease, like a lot of my asthmatic patients, we're like, oh, my asthma has been under control for years, and now suddenly they're coughing and shortness of breath a lot more. I'm like, let's start your inhaled corticosteroid again. Let's do it. All right. So I would be proactive immediately. Now, if those symptoms linger for about 8 to 12 weeks more, right, then you can start talking to that primary care physician about, hey, do you think this could be long COVID? But yeah, I would encourage anyone and everyone, after a bad viral infection, start being proactive afterwards. And again, it could be a very simple visit if symptoms resolve quickly, or at least the primary care physician can watch the disease trajectory so he or she understands where to intervene and potentially where to refer.
Great. Thanks so much, Dr. D. If you hang on.
I will hang on. No worries.
Have some time at the end, but I do want to bring up our next guest. Again, thank you, Dr. G. Dr. Campbell, who is joining us. So Dr. Campbell received his undergraduate degree from Georgetown University, his medical degree from Columbia University College of Physicians and Surgeons, and his master's in epidemiology and biostatistics from the University of Maryland School of Medicine. After residency at the National Naval Medical Center, he first practiced general pediatrics and later completed his fellowship in pediatric infectious disease at the University of Maryland. He has been a faculty member at the University of Maryland School of Medicine and its Center for Vaccine Development and Global Health since 2001. From 2007 to 2012, he lived in Uganda, where he worked for the U.S. Centers for Disease Control and Prevention. Dr. Campbell currently combines clinical care research and teaching at the University of Maryland. He is involved in a large portfolio of research endeavors, including testing vaccines for influenza, anthrax, meningococcus, CMV, RSV, pneumococcus, and SARS-CoV-2. Dr. Campbell is also a member of the Committee on Infectious Disease for the American Academy of Pediatrics. I am also a pediatrician. I had the pleasure of meeting Dr. Campbell during my first year, it was pre-pandemic, that much I know, because we were in person. So during my first year as commissioner here, he has been so gracious to offer his time to talk about pediatric COVID, right? And so we spent a lot of time certainly talking about adults and that high risk population, or older adults, those with underlying comorbidities, but especially as we're seeing vaccines become more available for children, it's critical to think about what does that mean for our pediatric population. So I'm glad to have Dr. Campbell on. First, maybe we can start talking about COVID-19 cases and case rates specifically in children, and why we shouldn't compare them to adults, because I think that's an easy go-to. So maybe we'll kind of start there to get the conversation going.
Yeah, thanks for having me, and thanks everybody for being on. I'm glad to be here. Yeah, so I think, as pediatricians, we kind of look at the world a little bit differently. I think similar to the way that parents might look at it with their children, and that is that children shouldn't be sick frequently. Children shouldn't shouldn't find their way to the hospital, and certainly children should not die from anything. And children, very rarely do die from any disease or problem. And so, I think what's happened over the course of this pandemic is, unfortunately, the media and others have often made this comparison of how bad COVID is in children to how bad COVID is in adults, especially in older adults. And of course, it's not as bad, but thank God for that. But what I've been trying to redirect people's sights to say, well, let's compare COVID in kids to everything else that happens to children. Like, how bad is it compared to the flu, or how bad is it compared to like things that kill children, like cancers and other things sometimes. So, and the other thing that I've been trying to encourage people to think about is, if you're thinking, well, should I get a COVID vaccine for my child, is, well, what else are you vaccinating? What else do you like? Have you already decided that you're going to vaccinate them against? And how does COVID compare to those things? So if you start off with the other diseases that make children very sick, COVID, unfortunately, has risen. Like in January of 2022, a few months ago, it was the 4th leading cause of death, overall all-cause death in children. And in other months, it's the 6th most leading cause, it's the 8th, it's in the top 10 every month since we've started. So it is mild for most children. So, I'm not I try not to scare people to think, oh, my child's going to die when they get COVID. Most children don't. The vast majority don't. But that's the case for most diseases in kids. So it's not mild when you compare it to other bad things that can happen to children. And then vaccine preventable diseases. We vaccinate our kids against diarrheal diseases like rotavirus or chicken pox or tetanus, or name any of the things that you've already vaccinated your children against. And there's just not a lot of those around. And even before we had vaccines, most of those did not lead to children dying very frequently. So COVID would be higher than the mortality for things like rotavirus, for chicken pox, for measles, for pretty much all of the vaccine preventable diseases. So I think having that lens, like, what do we expect for, in the health of children, and how has COVID fit into those diseases, I think is the better way, the better comparison than, how do we compare it to adult disease and adult severity.
No, I definitely appreciate that context. And, it was one of the reasons why we wanted to have you on, because I think it has been the default throughout the pandemic to think about, COVID severity, COVID symptoms in children, and compare it to adults. And we know that they're very different patient populations. Speaking of which, can you discuss any differences in symptoms of COVID-19 amongst children compared to adults?
I think, the primary thing is, as we just said, is that more children have milder disease. They have similar symptoms for the most part when they get symptoms, but in terms of the proportion that get bad symptoms, it's much less. So a lot of children actually are completely what we in medicine call asymptomatic, right? So no symptoms at all. So if we test them because they were exposed, or if they have their blood drawn and we test, there's ways of telling if they've ever been infected. And there are a lot of children, probably, 2 to 3 times as many children have been infected than have ever had any symptoms. When they get symptoms, the mild ones tend to be similar to the common cold. So low-grade fever, feeling kind of run down, maybe irritable, stuffy nose. There's been with Omicron, with this newest variant, there's been more like what we call upper respiratory issues. So things like sore throat. And for some of the parents out there, they probably, if they have toddlers or young children, or they did before, they probably know what Croup is, which is, this barky cough that little kids get. And with the Omicron variant, we're starting to see some kids have Croup due to COVID. Croup is pretty much never, so that's one thing that's different. Like adults pretty much never get that croupy, barky cough. So it's the same sorts of things you might see with flu, mostly respiratory, meaning runny nose, cough, sore throat, fever, and then generally feeling unwell. It can infrequently affect other parts of the body, and just like other viruses can do that. But for the most part, I think if you're looking to see whether or not, hey, I wonder whether or not this is due to COVID, it's going to be the same sorts of things when you're thinking about other respiratory illnesses like flu.
That's helpful. Now, speaking of which, knowing that in some instances the symptoms do progress, can you speak a little bit about MISC or multisystem inflammatory syndrome in children, which we know can be a rare complication?
Sure. Yeah, I think some people out there have probably heard of this before, and maybe others have not. It's an uncommon but serious problem that's occurring primarily in children. There's a little bit in young adults, but mostly in children. And mostly like in school-age children, where they get a COVID infection, and usually it's either completely asymptomatic, they didn't even know that they were infected, but maybe they were in a household where other people had it, or they have mild symptoms, like cold symptoms, like I was just describing. And then about a month later, they're well in that month, but then about a month later, they get quite ill. And so their immune system we don't know what triggers it, but it triggers this sort of what we call hyperinflammation, like too much inflammation. Your immune system somehow misrecognizes what it's supposed to do, and it inflames you when you're no longer infected. And it can inflame the skin, giving you a rash. It can lead to fever. It can give inflammation in the lungs, in the heart, in the blood vessels, and lots of the body. And some kids can get quite ill from it, even winding up like in our critical care intensive care units, because their blood pressures can go down, their hearts maybe don't squeeze as well as they should, things like that. So it's the way that parents would be able to tell whether or not their kids might have something like this would be if they have prolonged fever, if they're feeling very weak or short of breath, if they're having heart palpitations, things like that. And you may or may not recognize that a month prior they had COVID, but that is what is causing the trigger. There are similar diseases in kids, like this disease that we call Kawasaki Disease, and some others like that I'm sure you know about, but maybe others on the call don't, that also are triggered by some kind of pre-infection, and then weeks later you get this inflammatory response. And we treat it in a similar way. We try to dampen, calm down the immune system. And usually once we do that, those children get better. So they may need an intravenous infusion, or they may need some oral medications. It brings the fever down, it gets the swelling down and all that inflammation. And then we follow them afterwards to make sure that they don't have any lingering effects. But most kids do quite well afterwards, as long as it gets recognized and they get the appropriate treatment.
Great. No, that's helpful. I mean, we're talking about, this is maybe a child that has a normal functioning immune system. Can you talk about maybe vaccine recommendations for those children that are moderately or severely immunocompromised, right? Because just like we've got the high risk adult groups based on comorbidities, there are some groups in children that are higher risk that we want to be particularly mindful of protecting that group.
Absolutely. Sure. Thanks. Yeah, so I think parents of children who have immune compromised, and how do you get your immune system compromised? Some children are born with problems with their immune system where they just have trouble fighting off infections from birth because of a genetic problem or various things that can happen at birth. Others have diseases that the treatments for those diseases lead to problems with the immune system. For example, like a transplant. So some children need their organs transplanted or a blood transplant. And the medicines that we use associated with those to prevent the organ from being rejected can lead to immune compromise. Same with children with cancer. We use chemotherapy, which is the purpose of that is to kill the cancer cells, but it can also lead to killing some of your own immune cells. And then other medications that children may take for diseases, like they may take steroids, or if they have like inflammatory bowel disease or Crohn's disease, they may take those sorts of medicines. So parents of those children and the older children in those groups know that sometimes we have to adjust their vaccine schedule. So it's not only for COVID. So, we use different or additional vaccines for kids with sickle cell disease whose spleens may not work well, for kids who had cancer and have transplants, et cetera. So same for COVID vaccines. So the vaccines that we're using, typically what we call the primary series, like the first vaccines that you get, and all of you that have been vaccinated know this, are 2. But for children and adults who have immune compromise, that primary series, the beginning series, instead of 2 shots, it's 3. So, that's the simple way. The best thing is, of course, to talk to your doctors or your child's doctor and make sure that they're getting the right regimen based on their health. Because it depends on how immune compromised. There are some things like, Dr. G was just talking about asthma, where you may take an inhaled steroid. Those have a very minor effect on your immune system, and probably are not enough that it would change your response to a vaccine. So, it's important for parents to go to their pediatric providers for their kids and ask them, hey, does my child have the disease that they have? Does it mean that they need to have additional vaccines beyond the usual regimen?
Great, thank you. So we've got another question in the chat box that I'm sure is very pressing for many parents. So this person is asking, Miss Julia is asking for just general advice for parents for kids under 5 who aren't yet vaccinated. So obviously masks are now optional in most places. How likely are we, I presume, family members who maybe are vaccinated and boosted, how likely are they to bring COVID home? And just advice for parents, I think, that are working outside the home and that need to travel for work. I think this is probably a question on the mind of a lot of parents. So maybe we could speak to that some.
Yeah. So thanks for that question, Julia. It's something we've been working on now. How long has it been? 2 years on pediatric vaccines, and we have gotten vaccines all the way down to the age of 5, as you mentioned. And just this week, as you may have seen, there's the announcement that the FDA now has the data to review for kids all the way down to 6 months. So the one vaccine manufacturer, Moderna, has given them all the data that they need to be able to review. So hopefully we will, in the very near future, as long as that data pans out, as so far it looks like it will, to be able to vaccinate them. But in the interim, you're right, children who are unvaccinated still potentially remain susceptible. So what can we do? The good news is, if you're vaccinated and if you're trying to be as careful as possible wherever you are, at work, at play, at travel, to not get infected, it's less likely that you'll bring it home. There's no 100%. And, I think it is very difficult in our homes to be, continuously quarantining ourselves or separating ourselves from our family members. So most of us have sort of like set up, if you will, that bubble of saying, there's just no way at home that we're going to be wearing masks all the time, or never, not eating together, et cetera, because, there are a lot of benefits of all of those interactions. So I think you do what you can, and you treat yourself. If you do get infected, you treat yourself, you get treated quickly, and recognize if your child gets sick, that you get them for care quickly. Washing hands still is a good thing. If you are ill, quickly, as soon as you have symptoms, or if you're exposed, then going to get tested, because then, if you know it's going to be a brief time that you have to isolate or quarantine, then, that's doable, I think. But if it's just all year long saying, I'm worried I could bring it home, nobody's going to want to be, of course, separated or have that kind of distancing from their children. So I think, it's a balancing act, but it's a little bit easier now. I was saying before we started that the calls that I'm getting now are a lot better. As a pediatric infectious disease doctor, people asking me these sorts of questions rather than questions about the super sick kids that we were seeing just a few months ago in our hospital. So we do our best, and hopefully in about a month, we will have a determination on getting the vaccines into our youngest.
Great. No, I think that's helpful. I have my son turned 5 like shortly after vaccines were approved for that age group, so was very eager for him to get his vaccine, and it was like right around the beginning of the Omicron surge. So
Perfect.
Yeah, we luckily got him in, but I certainly understand the concerns and the angst as a parent. Especially because our children are going out into the world. So there's a lot that obviously we can do. We can mask when we're around others indoors, but knowing that they're going to be interacting with others can be challenging. So so another good question from Julie, and I don't know if we know the answer, but just wondering how prevalent asymptomatic spread is. Again, I don't know if we know, but certainly turn it over to Dr. Campbell.
Yeah. We do know that there is spread when people are asymptomatic. But when people have symptoms, they tend to have a couple of things. One is higher loads. And by that, we mean like if you could quantitate how much virus is there, you'd find more virus. And some of the symptoms that people have when they're infected are things that might spread that virus more easily. In other words, if you are coughing, it can spew out the virus to further distances than just speaking. If you're sneezing, then the secretions, the stuff that's in when you sneeze can get on your hands or get on surfaces, or, your kids or others could be exposed to it. But on the other side, when people have symptoms, they tend then to say, I better get tested, or I'll wear a mask, or I'll be more careful about washing my hands. So that sort of mitigates that risk and lowers it. But there have been studies done looking at how, I think what she's asking, what Julia, you're asking about is household spread primarily. And there have been studies done looking at like who spreads it in the house. Is it only adults? Is it only kids? Is it both? It's both. We used to think way back when that it was primarily adults, but I think that was because there were so many asymptomatic kids. They weren't being tested, and you may remember back a while back, we didn't have all the tests that we needed, and so we were sort of preserving them for those who were sick, and adults were mainly getting tested. We now know that kids get infected just as easily and infect others just as easily. So about 20% of all the documented infections in the United States have been in children, and about 20% of the US population is children. So they certainly get infected. But yes, asymptomatic spread certainly occurs, but probably less than symptomatic spread, just because less virus and no symptom. You're not like coughing and sneezing and getting those secretions on other things.
Awesome. Well, thanks, Dr. Campbell. If you'll stick around, we've got one more guest, and then I think we'll have some time for questions. Very excited to bring on the Health Department's own Rebecca Dane. She is our Assistant Commissioner for the Bureau of Maternal and Child Health. She has been with the department, I'm going to get the number wrong, I know it's more than 12 or 13 years, somewhere around there. She leads our Be More for Healthy Babies strategy. She has also been instrumental in supporting our vaccination work globally, but especially as it relates to pediatric vaccination. So I'm really excited to have her on today to just talk quickly about the health department strategy and approach to vaccinations in children's. And I think, one thing that Rebecca and the team have done well is recognizing that each age group, and as a pediatrician, I think about this a lot, each age group is a little different, right? So we had approval of vaccination of our 12 to 17-year-olds in May of last year, right? And the way that you reach 12 to 17-year-olds is different from how you reach 5 to 11-year-olds, right? So then we had our 5 to 11-year-old vaccine approval in November, and that required a different approach. And certainly as we think about children under 5, that's going to require a different approach. So again, excited to have Rebecca on to just talk briefly about how we approach those different age groups, some of our successes to date. And as we think about that under 5 age group, some things we may do differently. Certainly we'll have learned a lot from what we've done in the first age groups, but what we may do differently with this younger age group. Rebecca?
Thank you so much. And it's really fantastic to be here. And I will say that we have vaccinated 64.9, so just about 65% of our 12 to 17-year-olds are vaccinated. So we still want to get to the 80% mark, but we are really well on our way there. And for the 5 to 11-year-olds, we're at 30.3%. So we've got a way to go. And our goal right now is for the 5 to 11-year-olds and the 12 to 17-year-olds, by the time school starts in September, 80% of these kids are going to get vaccinated. And so we're really psyched to be working with the city to move that effort forward. And that translates into about 38,000 doses that have been given to kiddos over the last few months. And the health department itself has worked with partners to do about 300 pediatric clinics. So lots and lots of incredible work. And so I'll say that while there are different approaches for each of those age groups, each age group and our strategy in general has followed this dual prong approach. And the first is, it's very basic. What can we do to ensure that we have adequate supply of vaccine in places where people can access it? And then the other part of the strategy is how do we encourage people to actually get vaccinated, get the vaccine in the arm. And that's a lot about trust building and demand generation. And so for our 12 to 18-year-olds, we focused a lot on the city high schools and on places where teenagers hang out. And what we did and what we spent a lot of time doing was mapping out the city, finding out where all the vaccines, where all the kids live, where are their households, and then where are the schools that kids go to. And then for the high schoolers, we really did a lot of competitions between high schools. There was a fun competition where they got an ice cream truck to come down after which for the school that reached 60% the fastest, and a lot of real excitement with our city school partners. As we're expanding as we start to expand to the 5 to 11-year-olds, we kept up, that kind of competition with middle schoolers, but we also realized so much that the 5 to 11-year-olds are seeing their pediatricians pretty often, and so we had a very structured approach with our pediatricians. The one thing we'd want to say about a pediatric strategy is that we do not want to be duplicating the primary healthcare system. It's really important that every child in the city has a medical home so they're well protected in all kinds of ways. And so there's some background noise, Dr. Jaros. I don't know if that's my phone or there we go. Yeah, thanks. And so we are expecting to continue our work over the summer. And so how are we doing this? We're ensuring the vaccine supply by working with city partners who interact with children in neighborhoods. There's going to be a lot of summer camp programs, things like that. So we'll be working to make sure that those programs have educational materials and maps and maybe themselves have vaccine sites. We're also working on, continuing to work with city schools to figure out, we've got back to school clinics that happen every year. How do we make sure that COVID is a part of that? We're also making sure that any pediatrician who wants access to the vaccine, even if they're a small pediatric office and they can't really, they're not able to stock the supply of vaccine in their offices, we will transfer vaccines to those offices. We have a good transfer for pediatricians for those who want to be supplying vaccine. For those are the primary ways that we're working on the supply side. We're also making sure that there's transportation available for any person who needs it to get to those vaccine clinics. On the demand side, we continue to work with reducing vaccine hesitancy, but really the most important thing is to say, we as the public health department are here for the community. We want you to trust us, not just for COVID vaccine, but for anything that we're doing. And so we are understanding that there are many people who've not been vaccinated. And because parental consent is required, we make sure, particularly with our younger kids, that we are doing a education approach with parents, with faculty member, and with the kids themselves. We are also aiming to standardize what people are hearing through provider offices. We have a very strong pediatric provider and obstetric provider outreach program. We're doing training of city school faculty and parents. And then what is a really fun program is we have youth ambassadors that have been working with Morgan State University for throughout the last month. We've held multiple listening sessions and have about 18 youth ambassadors in city schools encouraging teens to get vaccinated, sending testimonials. And if you go to our bemorevax.com website, there are lots of testimonials. bemorevax.com, it's lots of testimonials from students and from others. So with the babies, we are really waiting for the authorization. And as Dr. Jarasa knows, Moderna has given, they've asked the FDA to authorize their vaccine. Pfizer is still there, but I think we're probably guessing maybe June, maybe, where we might see a vaccine out. It's all sort of up in the air, but we are prepared. And so the thing that we're doing differently is, again, we really want to focus on the pediatricians. There are a lot of pediatricians who aren't yet ready to be giving out that vaccine. So we know we also have to fill the gap through the health department. So first, we're just accessorizing the pediatricians with all of the tools we have, educational tools, et cetera, vaccine if they want it, giving them, the lowdown on how to get vaccine to their offices. And then we are also working with Judy's centers, which are centers that help that are wraparound services for families of 0 to 3, Head Start sites. We're working with summer camps and any other place, our home visiting programs, where we have 0 to 5-year-olds available. And we're dividing the city up into quadrants and making sure that we have a strategy for each quadrant, so there's nowhere in the city that's left untouched. We also are paying a lot of attention to our surveillance data. So we're making sure we know where are their parents, where are their older adults who aren't vaccinated in the city, because those are going to be areas that we really need to be focusing on, because we want to make sure those kiddos get vaccinated before they go to school in the fall. And so lots and lots of efforts happening. Again, our 2 clinics at 1200 East Fayette Street and at North Avenue, our Druid Health Clinic, are also open for vaccine. We love having people there. And we are really eagerly looking forward to the summer as being an active effort to get all of our kids and parents vaccinated.
Thanks, Rebecca. And I think you touched on it, but my one question is for parents and families who have not yet identified a pediatrician or primary care physician for whatever reason. Again, I'm a pediatrician. I would strongly encourage you to identify a pediatric clinical provider that will get to know you, your family, and your child. But in the event that you don't have a pediatrician or primary care clinician, where can that parent go to get resources or get their child vaccinated?
That BeMoreVax site will have all of the contact information that anybody would need. The health department's website also has that contact information. Those would be the 2 primary places to go. You can call our health department clinics. We can get you in for a vaccine, and I can grab that telephone number as you're speaking and put it into the chat box.
Great, and I see we've got it scrolling on the bottom. It's either
great.
And it's both. If you type in BeMoreVax, it's going to take you to bemorevax.org, but bemorevax.com works also, either one. And then we're going to also share that call number. It's 443-984-8650. I have memorized it. I've said it so many times, but we'll definitely get that on the screen as well. So we've got a little over 10 minutes left. Maybe we can bring back all of our guests and start to take additional questions. I know we got to a few, but certainly if you've got questions on long COVID, pediatric COVID, vaccinating your child against COVID, vaccinating yourself against COVID, by all means, would love to start to field some of those questions. So I'll start as questions begin rolling in, because there were a few things we didn't get to. So this question is for you, Dr. G. One question we have. So if I've had, or if I think I have long COVID, should I still get vaccinated?
Oh my God, 2 years into this pandemic, and I'm like still thinking about unmuting.
Yeah.
Yes, 100%. And a couple of things that again, the research is trying to catch up to in real time. But we have noticed a different timeline of potential symptom resolution for those who got COVID, developed long COVID, but were never vaccinated. And for many of them, it's because the vaccines just weren't available at that time, versus our patients who were vaccinated and then developed COVID and then long COVID. That latter group, their symptoms tend to be not as severe, and they tend to have those symptoms sometimes just self-resolve much faster. So from my standpoint, I would still emphasize the vaccine, just because that smart immune system, right, that's key here, not a strong one, a smart one as well. That seems to help with patients, even if they've developed long COVID, to keep those symptoms mild. Now, you may be saying, well, I have it now. Right, but remember, another reinfection could amplify things, and we want to make sure that you have all the right tools in place internally to keep that from happening.
One of the things we didn't touch on, Dr. G, but I think has been published is, what do we know roughly what percentage of people who get COVID, what percentage go on to develop long COVID?
Yeah, so then you're right. A lot of literature has been published on this, and I will say a number, and it sounds still pretty scary, but about 60 to 70% of patients still have a symptom, at least one symptom happening a year after catching it. And that symptom that tends to be the most common is fatigue. Now, I say this, the asterisk I will always put on there is that symptom, the severity of it is different for every patient. So recognize that this virus will leave some consequences of symptoms later on. How severe they are depends on who that person is. Like if I have a CFO of a company who's high functioning cognitive status, yeah, they're going to be rocked for a while until they regain themselves later on. So that to me is why, for me, the strategy is always don't catch COVID. So a good portion of people will still experience symptoms later on. How severe those symptoms are, that's the part that the research studies struggle with, mainly because I think they're very subjective. Like fatigue may not be as much of an issue for one patient, but may be more of an issue for another.
Thanks for that. So, Dr. Campbell, I have a question for you, and this is again one that I think we've gotten throughout. So, as we think about the vaccines for COVID, one thing that we've heard is concerns about how this might affect fertility or puberty or pregnancy. Can you speak to what we know about vaccines and their effects on puberty, fertility, pregnancy?
Sure. We've never had a vaccine before that has ever had any concerns for those issues. There have been rumors of other vaccines that that people thought maybe would lead to things like early menopause, what we call primary ovarian failure, fertility issues, or issues with babies, after moms get pregnant. But once those rumors come up, then people do large studies, and so far for every vaccine, they've been disproven. And that's what we're seeing so far with the COVID vaccines as well. The rumor that led to this issue of people thinking that it may affect fertility started with someone who said, well, I wonder if the spike protein, which is the covering of the virus that causes COVID, I wonder if it has any protein similarity to any human proteins, and then looked at all human proteins and said, oh, there's a protein on the placenta that has a few of the same amino acids in the same order. So I wonder whether that means it's going to affect, fertility. Well, you can do that for every protein, like every plant protein and bacterial protein and kangaroo protein, and you're going to find things that are going to have some similarity with humans, but that doesn't mean it's going to affect their fertility. So what happened after that is multiple studies have been done to show that there's absolutely no effect. If anything, especially for pregnant women, it protects them from getting COVID, and pregnant women who get COVID while they're pregnant can get very, sicker than same age women who are not pregnant. And it protects their babies. It's been shown now that in the period, if moms get vaccinated around the time they're pregnant or while they're pregnant, those antibodies that they make that protect them go through the placenta and then into the baby's blood. And it's like vaccinating two people at the same time. And that baby gets their protection early on from mom. So even though there may be stuff out there in social media or elsewhere where people have, I wonder, could it be, I want to be on the safe side. I mean, look at the real data, and there's only evidence against what you brought up, nothing for.
Thanks for that, Dr. Campbell. We have another question, I think probably best directed towards Dr. G in the chat box. So relapsing or exacerbation of symptoms after activity is an issue for a percentage of people experiencing long COVID. What advice are you giving when that happens? Is there anything that can be done to stop that from happening?
Yeah, no, again, so, and long COVID is not one that, for many patients, the symptoms they experience isn't like a static, linear symptom manifestation. For many, it's a relapse. Like they got better, kind of a relapse remission. They got better and they came back and so forth. So this is key to understand as we understand long COVID. Everyone's experience with it is a little bit different. I've had patients who graduated from our post-COVID clinic only to come back months later. So from my standpoint, what I would always recommend is, first of all, what are the symptoms that they're experiencing that they want to have better symptom management over, right? Once we have that understanding, then we begin to target how to best approach it. And I would say, and I'm saying this because I'm leading into one symptom that we really try to tackle thoroughly, and that's fatigue, as well as potentially some cardiopulmonary manifestations that patients don't like the breathlessness that kicks in when it shouldn't be, or the heart rate that rises when they're like, I'm just sitting. So we actually team them up with our physical therapists and our physical medicine and rehabilitation doctors to teach them techniques on energy conservation. And so those techniques, they actually begin to implement into their everyday lives in order to keep those symptoms from actually exacerbating, trying to mitigate their symptoms and those tolls on them. As one of my PM&R doctors mentioned, it's like a patient with an amputated leg, like you can make them functional again, it's just an adaptation. So patients with long COVID with certain symptoms, learning how to adapt to them until we come up with cures, et cetera, is actually life-changing for them. So that's what we try to teach and manage, knowing that the symptoms are going to be sometimes relapsing over time.
Great. Thanks for that, Dr. G. We've got a couple minutes left, and I did want to make sure we got to this question because we're on the eve, I believe, of approval of vaccine in our younger children. And so maybe starting with Dr. Campbell, we've got some parents on the line, but so maybe some of us as parents can answer too. But for parents who've not yet decided to vaccinate their children, what is your message to them?
Sure, thanks. I think the most important thing is to talk to the person that you trust the most that helps to care for your child and have a conversation with them, just like you would for other vaccines or for other medical advice, whether that's the nurse practitioner in the pediatric office, the pediatrician, other trusted people. My main advice is don't use social media or other things on the internet as your way of making healthcare decisions for your children. I think it's important for all of us to be educated consumers and to get all the information that we can, but then also to have good conversations with the people who do this day in and day out. Another message I've been telling people is I do this work, like I do the vaccine studies, and then people think, oh, I'm going to market or promote them. I'm waiting also for the data. I did the study on the data that was just presented to the FDA. I don't have all of the data yet. Those data come out once the FDA releases them, and I'm looking forward to it. I think all of the what we call top line data are very encouraging. And so as long as all the nuance, the tail of the data look as good as the sort of top line, then if I had young children, I would want to vaccinate them, and I would encourage others to. But until we see that and until those experts review it, these vaccines are going through the same process that every other vaccine that your child got went through. And that is external advisory committees, FDA review. The reason why we don't have it today, even though it was submitted to the FDA yesterday, is because they look over this data with a fine-tooth comb over about 4 weeks. They have a whole team of people doing that. Any questions, go back to the sponsor. Anything comes to this VRPAC, which is the advisory committee. Then it comes to, like, I work for the American Academy of Pediatrics as well. We review all of the data and say, should children get this? Which children should get it? At what time? So there's just this army of people reviewing the data who, that's what we do day in and day out to make sure that it's safe and effective. And I'm not saying just blindly trust them, but do go together with those data and your care providers, and then make an informed decision, not a decision based on what maybe somebody anecdotally said on social media.
No, thanks so much for that, Dr. Campbell. I know for myself as a pediatrician and parent, I looked at the data. I looked at the clinical trial data for both adults and kids. I probably looked at it a lot closer for kids than I did for adults, knowing that my son was going to become eligible a few weeks after it was approved. So I totally understand wanting to review the data. So what I heard Dr. Campbell say is, do your homework. Go to those trusted sources that can provide you with information that is intended to help you as well as your child make the right decision for you. So for me, this has been an amazing panel. I want to again thank our guests today, Dr. G, Dr. Campbell, Assistant Commissioner Dane, for just being here, for answering viewers' questions. Really appreciate you all. And thank you to all the viewers who also took time out to tune in. This will be available later, reposted on social media. So if you missed anything, feel free to check us out again. Again, thanks everybody. Have a good Friday.